Well, hello everyone, and we are welcoming you to our little debrief here. We are with International Foundation for Autoimmune Autoinflammatory Arthritis, or AiArthritis for short, and we are attending EULAR 2020 e-Congress, which is the rheumatology scientific meeting, one of the biggest two of the year, online with everyone else. So my name is Tiffany, and then I have some friends here.
I'm Deb Constein. I am in the Madison, Wisconsin area. I am a patient with rheumatoid arthritis, and I've had it for 36 years. And yeah, lots of other comorbidities, but anyways.
And Patrice.
Well, my name is Patrice, and I live in Northern California. I've had RA or something along that lines for the last 9 years. And I have some comorbidities as well, and just happy to be here and so very grateful that you guys included me in this because it's just such a wonderful experience.
Oh, well, that's awesome.
Without you, Patrice.
Yes, we're happy. That's one of the benefits that this scientific conference has gone virtual, I would say. As usually Deb and I we have gone to these for the last several years together, and it's very expensive, but it's necessary to go. So at least we're learning how to involve more people when we do go back to the conference remotely. And so this is going to be helping us with that as well. But what we're doing here is we are representing what we're calling the core team. And so always at our organization, we attend the two biggest scientific meetings of the year. This one, which is the European League Against Rheumatism, or EULAR, and then that is European based. And then there is also the American College of Rheumatology, or the ACR, that also happens in the fall. And so since we attend both of these, we usually have to do it in what, Deb, 4 days?
Yes.
4 days, trying to
crunch, yeah.
see
and
everything.
We typically miss a lot of the sessions too, so that's the other positive.
Yes. So this year, because of COVID, EULAR is decided that they would take the conference online. And the fun part about that is that we is always trying to go through 4 days and learn all of this and pick and choose what we can see. We have access till September 1st. So that's pretty exciting. And we were able to bring Patrice along with us as well. So there's 3 of us now at this conference, but there could be more if you want to join us. So we'll tell you a little bit about that here at the end. But what we're doing is we've divided the sessions that we would normally want to see that are relevant to our mission, which is to help others like ourselves living with autoimmune or autoinflammatory diseases that have arthritis as a major clinical component, or AiArthritis. We like to help them, people like us, to have a voice alongside other stakeholders as equals so that we can impact education, advocacy, and research. And we thought, well, come along with us when this is research based. And we went through, the 3 of us, and we picked out what we felt of all of the sessions the most relevant to our mission. And so what we're doing is every Thursday on YouTube, we are having these debriefs, because this is what we do, right, Deb, when we go to a conference?
Yeah, we do. Yeah, we absolutely do. We usually kind of talk about the day and kind of go through the highlights of everything we've learned. And we're writing it all down in a succinct way, just to kind of, and we talk through it, what I've learned, and then Tiffany will bring up points of things that, jump out at her from what I'm talking about.
Now,
having
Patrice,
a conversation.
Patrice is being thrust in to the world of conferences.
Yeah.
I think next year when we can go in person, I'll be an old pro at this.
I saw it's in France next year.
Pardon me?
It's in Paris. It's in Paris next year.
I saw that.
It was supposed to be I just poked myself right in the eyeball. For those, this year it was supposed to be in Frankfurt, Germany, and that's important to note because when we do take these debriefs and then open it up to bigger discussions with you, possibly over the next couple of months, there will be somewhat of a German theme because we're trying to keep it as true to life as being at a real conference.
Authentic, yes.
Authentic. So in saying that, this week we have 4 sessions that we have chosen that we have all been watching throughout the week, and we are going to give you a brief debrief. And what that really means is we're going to give you a glimpse into what we learned, and then we're going to invite you back to talk to us about it a little bit more. So speaking of COVID canceling the in-person meeting, that's 3 of the sessions that we attended this week. There's been a lot on COVID.
Yes. Which, I mean, is actually, it's refreshing. It's nice that they're hitting current and relevant topics. And again, it's one way of bringing it right back around for us.
Absolutely. And as an organization, just before we jump into this, as an organization, we've been doing a lot also with COVID-19 because it is so relevant to our rheumatology community.
Yes.
And so we're going to tie that back in with you as well as we go through this, so you understand better what we do as an organization and why it's important that we are attending these events and being part of these sessions. So we're going to start by jumping off on the COVID-19, since that was 3/4 of what we watched. And there were 3 specific sessions, but we're going to bridge them together. One of them was called The Consequences on Rheumatic Diseases, on RMDs. And we'll kind of start diving into that. There was another one that was for healthcare professionals, but there was a lot of really relevant information.
Oh, 100%. Yeah, it was really good. Yeah.
I thought was fantastic. And then there was a third that really focused on the current research using our rheumatic drugs to possibly help those that are most impacted seriously by COVID. And that was just interesting in itself. So we'll just start off by, I'll start off by mentioning the registries. So you may, as a person living with these diseases, have seen links to online to sign up for this registry. So they're everywhere. I was kind of glad that we had a slide that showed a map of how these are spreading out, because there's a lot of opportunities.
Interconnected, right.
That's what was good to see. I was getting a little confused myself with how many registries there are, but essentially when COVID-19 came about in early 2020, and especially because our rheumatic disease, our rheumatic drugs were kind of the first on the market to be tested for use, it became really apparent in the rheumatology community that we needed to be at the forefront of the research. And so a global group of rheumatologists came together and formed the COVID-19 Global Rheumatology Alliance, or GRA for short. And after a lot of discussion on, do we do our own database? Do we build off someone else's database? What they ended up realizing is we need our own database, but since there's other people who have existing databases, they could feed some of that information. So it's really a global connected effort in the rheumatology community that branches under this registry. So we will provide you with links to participate in those. And we'll talk a little bit about more of those when we get into our breakout conversations that we'll invite you to. One of the things I did want to mention before I turn it over to the other ladies to talk a little bit about what some of the registries have found and some biases that come along with that we want to point out. I do want to mention that, as I said, our organization is doing a lot in COVID-19, and we even have over a dozen AiArthritis Voices 360 talk show episodes just on this. And speaking of the research and the registries, I did an episode just about a week ago talking specifically about my potential experience with COVID-19 and encouraging everybody, if you think you had it, regardless if you no or not. If you
Yeah,
think you did, please have your voice count, because it's what you're going to hear us talk about a lot in this review is it's too early to know too many answers, and we need more data, and the only way to get data is to speak. It's for us to make our voices count. So we will make sure that we provide that information to you at the end on this video, but just to know that we are doing a lot of work in the COVID world, including being involved in this GRA. We have been behind the scenes and actually participated in helping create the patient survey. So speaking of the registry, Deb, I know there were a couple highlights. You wanted to keep it generic, though.
Yeah, for sure. There was one in particular that actually talked about certain rheumatic conditions that were more likely to require hospitalization versus others. They said that a higher percent of people who were hospitalized, they thought had lupus and vasculitis, and patients with psoriatic arthritis and ankylosing spondylitis were less likely to be hospitalized. Now, as far as that goes, I want to preface that in saying, lupus actually affects more organs, so it kind of makes more sense that, it would get more complicated. So I just want to preface that in saying that. And they also talked about comorbidities, things if you happen to have more comorbidities like hypertension, lung disease, diabetes, cardiovascular disease, or any kind of chronic renal or kidney issues. They talked about those comorbidities and being more likely to be hospitalized. And then the last one that I'm going to comment on is steroids. They said that glucocorticoids, which are steroids, were linked with hospitalization, but other medications were not. But again, I want to preface the whole glucocorticoids with the steroids. It was talking more about higher doses of steroids that you were more likely to be hospitalized. Tiffany, did you want to say anything more to that?
I did just want to add to that, because there was the third COVID that I went to for us. It talked a lot about the current research, and Deb made air quotes before, and I'm going to use air quotes again when I say research, because these are the research, even in the registries. And those are experts that are collecting it, experts that are analyzing it. What we need to understand is that in order to really, in addition to the biases, which Patrice will help us with here in a second, is clinical trials. There needs to be actual organized clinical trials to fully understand the data. There was a debrief we did last week, our first debrief, where we talked about let me try that again. Hydroxychloroquine, and it was called "All That Glitters Isn't Gold," with the takeaway being that something may look really great in the beginning on a few people, but real research takes a long time to get a lot of people included so that we can thoroughly test. Okay, so one of the things though that they talked about was this idea that they've been testing a lot of our drugs, which brings up so many questions, which is another reason we have to make sure our voices are heard. But they tested some that will be familiar to people in our community: Kineret, Actemra. So there were a couple that were for giant cell arteritis. We don't cover that, but still in the rheumatic conditions. And the long story short is that there was information showing that the survival rates were improving on our drugs. So that was promising, but what we have to remember is that it's early, and we need organized clinical trials. There will be a big one coming up in France. I don't know how to say the word. It was on a slide, so I don't know if it's Corimuno or Corimuno 19 study, where they're going to be testing several it looked like almost 10. I didn't count, but several of our rheumatic drugs to see how they are impacting the improvement. So that was exciting. But when you mentioned steroids, Deb, something that stood out here was there is information showing that when a patient gets to that 10% where they're that end worst phase, that steroids can be beneficial. But what we have to understand about that too is think about it in our disease. So right now, like Deb said, getting in the hospital might be higher if you're on a higher dose of steroids. So it sounds kind of weird to say,
yeah,
not good in the beginning, better at the end. But think about why we as patients are on steroids. We typically get on them because we have severe disease activity. Right? So if you think about it in that logical sense, I could see why somebody having a cytokine storm or, you know, a high level of inflammatory experience, what do you do to stop it? So our reason for encouraging people to lower their doses of steroids now, or not ours, the rheumatology community recommendations is so that our immune systems are higher. So once you already have COVID and you're at that last 10%, your immune system is already, that's not the biggest issue anymore, right? So it's getting the inflammation under control. So that's where that difference comes in. But we'll definitely talk more in our breakouts about this one, because I found it really, really fascinating. And I thought, honestly, it was going to be pretty hard to follow or really dry, because it was so, but I sat there going, like, I wanted popcorn. Yeah. I was like, man, this stuff I was totally geeking out.
Yeah.
So anyway, I digress, but let's go back to, we're talking about this research and the low amount of numbers, but Patrice, we were talking right before this. One of the reasons why we have to take everything with a grain of salt is because of the biases.
Yes. Yes.
Tell us more about that.
So they were saying that the data can't tell us that there's no known denominator right now for the population at risk. And they can't draw the conclusions about the diseases or severe disease effects. I am 65, so I am supposedly considered a very high risk.
Damn, you look good.
Yeah, for 65, I'd say the same thing.
Sorry, I digress again. Anyway,
we have fun even in scientific meetings and things like that. We gotta keep it light.
Okay, so biases, go right ahead.
So, you know, so I'm supposedly in this higher risk category, which in and of itself, COVID is very scary, but when this was all coming about and they kept saying, you know, people with immune compromised systems, but also tack on 60 years of age and older, I was really terrified the first couple of weeks that the information was coming out. But now they're saying that there's just not enough information out there to target my group or older Americans or older citizens.
Yeah, and there weren't enough tests. And I mean, we don't have a denominator. We do not know this amount out of this many people. We don't, because we don't know what this amount of people are. An unknown. There were some others too, like I saw they were talking about in the UK, which keep in mind other places in the world handled the restrictions differently. In the United States, for example, people were still allowed to go outside or go to essential places, which were like grocery stores, liquor stores. I'm just saying, you know, there are just different places that you could go. Whereas if you look in other places in the world, there was no leaving your household at all. You were
literally locked down. Yeah.
And so one of the things they talked about with these global registries and these global data is that we also can't really know a denominator of how it would affect our community because people are in lockdown. And then even as the restrictions lift, there are people that are high risk that are still they're shielding, they're still staying home. So realistically, which is great, not getting COVID, but we don't know the the real risk because we're not all out there together, if that makes sense. So again, a lot of unknowns. There were some others, Deb, I'm trying to look through my notes. Do you remember a couple of the other biases?
You know, that those are the ones that stand out to me right now.
Women.
Oh, women. Yeah, women.
Those women.
Yeah, they talked about women, but then another study will target men. And, you know, it just depends on what studies you're listening to.
In the registry, in particular, the data that came out said it was almost, I don't know the percentage, but a very large percentage of women participated.
Mm-hmm.
And in global statistics of the general patient or the general population, it tends to, they believe again early, that it affects men more and people of color. Right. So if you're looking at data and you're saying, well, it's affecting us in this way, meaning the rheumatology community, and predominantly white women participated, that's a bias. Because we're not sure. The other thing that I thought this was not mentioned is biases. They pointed those couple out, but I just picked it out because of our community. The people who were most affected were rheumatoid arthritis, as opposed to like spondyloarthritis or psoriatic arthritis. But first of all, more people are diagnosed with rheumatoid arthritis.
Yeah, exactly.
Whether that's true or not, I mean, Patrice and I are living proof of that. Yeah. My original was RA and changed, as hers is up in the air right now. And then the second thing is we just know that in our community, every disease group sort of has their own personality, and RA is
vocal.
Is a very vocal group.
Vocal.
And so I could see that when it said RA is the most, I kind of went, no. Yeah. That's exactly, just because that's who answered the survey.
Right. They're the first ones to jump at filling out the surveys and things like that. Yeah.
So that didn't surprise me, but it also wasn't something I picked up as an important statistic.
Right.
In the grand scheme of things.
It's a learning curve right now. So again, you know, listening to things, just take things with a grain of salt as it goes. Yeah. We're going to be developing such more robust data as it keeps, as we keep studying this COVID.
And then before we move forward to the next part of this, still on COVID, I also wanted to point out when Deb was mentioning some of those comorbidities and things that we were finding from the GRA, the Global Research Alliance, is that is very in keeping with the rest of the world.
Right.
Non-rheumatic patients, age, like Patrice mentioned, comorbidities, that's still the same in what we're seeing as people who were worse off.
Right.
So that's something I think that's really important to mention.
For sure.
Let's move on. Got my notes here. Let's move on. Oh, this was interesting. Deb and I totally nerded out on this one.
Oh, it was good. Yeah, it was good. We all.
Patrice, you saw this one. This was the one on the recommend. Maybe you did the clinical practice guidelines. This was interesting. So essentially, we're talking about research, and right now it is June of 2020. COVID started in January of 2020. New. And what typically happens when research occurs is there are publications, and there are clinical practice guidelines that are followed by the experts in order to ensure that the data and the outcomes that they publish are robust and inclusive of all stakeholder voices. And interestingly, I shout out, I can't even remember her name, but she was amazing. And she was talking about, they took the recommended guideline criteria and they dissected it. Could you tell us a little bit more about that, Deb? Because I know you and I were just really
what they actually talked about, again, there were 188 of these guidelines that she went ahead and researched, she and her team. And what they came to the conclusion of is that Okay, so she looked at the timeline and she started this in February through June. So 4 months, and these are the ones that she came up with. There were 188 of these guidelines that they were studying. And they talked, so what was kind of sad was, and I'm looking at the slide on my phone right now, it said overall, there was a complete lack of appropriate methodology and rigorous strategies in guideline development process. So, you know, when they were rolling these things out and, you know, publishing this data, they were leaving huge parts of research out.
Right. So so they literally took like the clinical guidelines that are supposed to be followed, like tick, tick, tick,
Yes.
tick, tick. And out of those 188, tick, 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 meeting all of the boxes, they ranked them into like this one hit all the boxes. So it's considered the most robust. They followed the clinical guidelines, and then it went down in ranking. There were only 8, right? Is that what it was? 8 of them.
That was it. Yep,
that ticked all the boxes out of 188.
Yeah.
And then even more so.
Yeah.
Go ahead.
Yeah. So one other piece was that just jumped out at her in particular as a researcher. She said, patient and public involvement is recognized as a key component of clinical practice guideline development, but only one guideline involved patients in the development process. I mean, that's jaw-dropping. And yeah, and she even said that it can't, you know, even going back to the methodology, that they were leaving the methods out and for being researchers. And she said that, you know, it was not even rushed because one of the best ones was within the first 6 weeks. And, you know, it was all done.
Possible. It can be done.
Right.
And the other part of that, just on it's possible it can be done, is this is just me theorizing here, but perhaps the reason why patients weren't involved in those first is because there was such a rush of rheumatologists and researchers to get together to like pressure to say people need our help. And that's why the patient voice was missed, because they were trying to get the experts together. But we really want to encourage, even in times of emergency, we are experts. Yep. Our voice we are equal. That is our whole mission. We are equal stakeholders to solve problems. And if our voice isn't included, then the entire scope of the problem cannot possibly be solved.
Nope.
So, you know, I get it, but let's not go backwards.
Yeah. Yeah. And she even said there was lack of transparency regarding stakeholder inclusion. So we were left out completely.
Yeah. So that was just that was really interesting. And again, you know, when we go into a bigger discussion with anyone who wants to join us after this debrief, we'll give you information on that, how you can do that as well. We can definitely answer questions and talk more about how, if you're interested in getting more involved in research or opportunities when they arise, we do that. So we can certainly help. Let's move on. Still on COVID.
Yep. Haven't moved.
Haven't moved from COVID. But again, there were 3 sessions we reviewed. So 75% of what we spent our time on this week were COVID ones. And this was there was a lot of it was interesting. I keep saying, I feel like I'm overusing the words, but it was on rehabilitation. Mm-hmm. Does somebody else want, because does somebody else want to take the lead on that one?
Do you want to take a hop into that one?
They were talking about, like, if you have had COVID, how you need to have a rehabilitation plan in place. Just as if you had a surgery, let's say you had a knee replacement or something, and you know your doctor and your physical therapist are going to have a plan for you. And this is what they were recommending for this as well. You know, which makes a lot of sense. Mm-hmm. And, you know, on top of that too, was the psychological impact. I have a degree in psychology, so this is very, very interesting. It's the stress and the anxiety and, some people could handle that very well, others can't.
Yeah.
Mm-hmm.
And I actually have some of the statistics on what relating to that psychological stuff. It talked about statistically significant higher anxiety scores were observed in females, patients on glucocorticoids, steroids, and biological agents, so our biologic medications that we take. And they also said, which was also interesting, was that there was no difference in the anxiety score with regards to age, educational status, and employment status. So that kind of goes back to what Tiffany mentioned earlier, the UK versus where we are. They were completely locked down, and that's where the study came from. They were polling people, and people were, completely locked down and depressed and, segregated from any other human beings. That's not like what is existing here in the United States. But
Although there is still
yeah,
a lot of
I'm not
depression
minimizing.
and anxiety for sure. But
Absolutely.
some of the things so we're definitely interested as we explore the anxiety part of this more, is we would like to really understand from wherever you are in the world, and your restrictions are different, what did cause you the most anxiety? I think we could agree that the things we've been seeing regardless match for generally seeing your doctor, the meds, are my meds going to make this worse? Are they going to make it better?
Yeah.
So all of that the unknown. Also kind of interesting, a very strong number, and I just wrote strong, so I don't know what the percentage is, but what it felt that telemedicine eased their anxiety. Mm-hmm. Because they didn't have to go to the hospital, and they had they could have access to their
I actually have the number for you. 86.6%.
I almost said 90, so
you would have been right there.
I was close. Went over a little bit.
Yes.
But so we're going to explore that a little bit more, because like Patrice said, when you're talking about rehabilitation, it was so interesting because, we whenever you have a disease, and they made that really clear. They kept saying COVID-19 is a disease. And when you have a disease, you need to also think about the recovery plan. And so one of the things I did want to point out that I was glad that they talked about was not only the lungs, but cardio. They said specifically cardiopulmonary, which is lung, heart combined. Again, don't know 100% sure if I was affected with COVID or not, but whatever got me went right to my heart, and I'm still 3 months later dealing with pericarditis. So I am very happy to hear about that, and honestly never thought to myself, regardless again, if COVID did this to me or some other weird virus that just happened to happen at the exact same time and be strong enough to get to it. A lot of coincidences, but let's just say whatever it was, I wasn't thinking about a recovery plan other than make this go away.
Yeah.
And so that made me think too. And then as a tie-in kind of to what both of you said, is this psychological and stress with the anxiety. And even if you didn't have COVID, we all are living in this very different time. Granted, it's not as much of a new normal for those of us who are used to living with chronic illness, but it is still different, and there's some isolation that we're not maybe as used to as normal, or maybe not seeing family or friends as much. So all of us should be thinking of a recovery plan for the psychological part.
Absolutely.
Stress and anxiety and depression that comes along with that, which eloquently leads us in, I think, to our last pain, right?
Yeah.
We got through. All right.
Brings us right back around.
Yeah, so let's go right into that, and then that'll wrap up our debrief for this week.
I have a couple statistics that we found kind of interesting that kind of started this session, and it was pain mechanisms, and the statistics are 1 in 3 adults live with chronic pain, 1 in 12 adults suffer from high impact pain, and 2 in 5 report unsatisfactory treatment. So Patrice, do you want to roll with that one?
Yes, so and this was also based on, is chronic pain a disease? how many times have we heard in our world that the pain is all in your head? I've experienced that a lot. And then she went into the definition of a disease, and you can actually go into any dictionary and look that up. But then, what is the pain definition? And we all have pain, and she was saying it's an unpleasant sensory and emotional experience associated with potential tissue damage. And so then she went into the receptors. I'll let Tiffany go into all that. That's a little on the scientific.
Nociceptor. So
Yes.
There was a lot of talk of nociceptors, and essentially what that is, it's the pain receptors. So if you feel pain in your body, then your body's alerted, and the stimuli alerts your brain and says, ouch, this hurts, and then your brain responds. So that's the nociceptors are part of the physiological part of the pain that carries it to the brain.
Yes. Absolutely.
So, but yes, so one of the things to build on what Patrice said and to carry on that about the nociceptor is, I circled really big. She said she said pain is a brain generated experience.
Yes.
And then I also, and where did I have it? I wrote it down here because I titled it right there. Where is it at? Pain. It's all in your head. So just like, well, that was a very close up. Sorry about that, everybody. You're right in my nose. But just like Patrice said, that really kind of resonated with me, and we'll go over a little bit more of what we learned in the session. But just as a side note, I can't tell you how many times I've heard that from people around the world is the doctor said, oh, it must all be in your head because you don't have positive labs, you don't have, imaging or whatever. It must be stress. You must be depressed. I mean, all of that we've heard. And now here we are in this session talking about how pain really has these two sides. And one is the nociceptor, or the physical part, that research has really spent a lot of time on and understands. But once that pain physiologically happens, then it triggers to our brain, and our brain perceives the pain, and that is variant per the individual. And so I just never really thought of it that way. And it made me wonder, like, so when people are saying it's all in your head, are they being rude, or are they citing, science? So it just opened my eyes to a different way of looking at it, I guess.
Right.
Yes.
Right.
So,
there was also the biopsychosocial model for chronic pain. The more scientific side was, again, pain being in the middle, and then you have your psychological side, your biological side, behavioral, and then your sociological side. And, for instance, the behavioral side would include sleep and diet and exercise and things like that. And your biological is your, the pathology of your joint, if it shows inflammation, or your genetics, things like that. But then it actually showed a model from the Arthritis Foundation that shout out to the Arthritis Foundation, that they have a chronic pain being in the middle, and it's got a picture of a knee and someone kind of holding the knee and it looking inflamed red. And all around it, it shows like disability, fatigue, stress, diet, your relationship, sleep, depression, your physical, abilities, disability, things like that. So it's all surrounded, all encompassed in one thing. So,
right. And it was, and the way they had the slide too is they had sort of the bio mechanisms, the physical, and then they had the Arthritis Foundation's model on the other side that sort of showed what happens next. So you got the physiological, and then it goes into the social, what happens to your fatigue. And, it's the result. It's like, and that goes into that mental state and how we cope and how the pain influences all of these economic factors of our lives. So really super interesting. There was another, and we'll have some of these slides for you if you would like to join us in broader discussions on this. But we keep going back to this depression and anxiety, but there were studies that they've built on specifically on psychiatric disorders that focus on depression and anxiety, and there's models, right, that show a direct
TMS. Yeah, the TMS.
relation.
Yeah, exactly. And the TMS is actually a brain stimulation that is been researched for years and been used for years for depression and things like that. And she is using the model to, focus on pain and actually bring this type of, brain stimulation to the pain side.
I think it was ultrasound or something. There was
magnetics. Yeah.
And that literally does some kind of stimulation to your brain. And while they didn't go into it, it did suggest that it could be an alternative way to deal with pain, stimulating the brain in ways that are not pharmacologic. That are not pharmaceutical. The other thing, Deb, that really stood out to me was when you're talking about that, we're talking about brain messages and the brain signature. I just really like that because our organization is very invested in precision medicine. We just understand from lived experience with these diseases that even if you have the same diagnosis, your journey is going to be slightly different.
Yeah.
We are all
in
our own ways. And that's why we believe in order to fully treat these diseases the way that they need to be addressed is based on an individual. And so they talked about these brain signatures. And she said in kind of parentheses, I have biomarkers. So those are specific markers in your blood that typically that will show up that differentiate you from other categories of people. And the research that they're starting to do is, she said, is so powerful with these metrics that they will be able to distribute these solutions for pain, not only at a population level, but also in a treatment per individual, which is leading them towards more precision medicine. So that all was extremely fascinating. And Mike, I know we could talk for hours on this one.
Yes,
we all really enjoyed it and felt that it was so relevant to our population. Did I miss anything with that? Are the main points?
No, I don't think so.
So I know I'm really looking forward to seeing how this is going to go forward in the future. And how, oh, thank goodness somebody's addressing this, finally. Yeah,
that's actually a good point. I forgot to mention that, Patrice, that you said finally, because it's only been fairly recently that chronic pain, was even added to the international disease codes.
Yes.
And so that in itself, that's how they started off the presentation, talking about, is it chronic pain on itself, or is it associated with an existing disease? And I mean, just so much we learned from this one. But yeah, I think we're all super excited about where that's going to end up. I think we touched everything.
I think we did.
Yeah,
I think it's just linking everybody back now. And, one shout out I'd like to make before Tiffany adds all those links is if you guys actually enjoy, what you're learning from us, going to conferences costs a lot of money. When Tiffany and I've got a dietetic and biology degrees. So, it's of interest to me, and, we're helping to disseminate it and bring it back to you in easy enough terms. And it costs money to do that and to go to these conferences.
And to spend time.
Yes.
Debriefing, and there's a lot of time that goes into this, no doubt.
So if you like we'd like to send you back to, AiArthritis and, donate. Please donate towards these things to keep this happening. We want to keep sharing this information because it's relevant to every one of you. So please, you know, to keep this going and to keep us going to conferences. Again, international flights are not cheap, and you know, we are vested in, you know, bringing that information back to you. So consider donating. So anything is, you know, welcome. So please
Appreciate
consider
it. Thanks for mentioning that, Deb.
Yeah.
And you can do that at aiarthritis.org/donate. So you can go right there. Some other ways to also get involved is we keep mentioning we're at EULAR and we're the core team. Well, we also have a group of 4 or 5 additional volunteers with our organization who have signed up as the extended team. So we're doing the main debriefing, meaning we're going in and we are searching through the sessions that are relevant. We are watching them, we are taking them and turning them into more layman's terms, so it can be patient-to-patient conversation. But if you are really super interested in this kind of stuff, guess what? You too can watch all of these sessions for free, because EULAR has opened it up to patients who have rheumatic diseases free. And you have access till September 1st. So you can not register and you can just join us for debriefs, and also, we're going to continue these conversations every other week through July and August of 2020. We'll be focused on the things we're debriefing. We'll funnel them down into, I know we're going to do pain and I know we're going to do COVID.
Yep.
So it's 2 of those 4. And we are going to welcome you to join us live on YouTube, and we'll give you more information about how you can do that. But if you're interested, you can go to do these on your own as well. You can go to congress.eular.org and you can register there. And you also can join us. So what that means is come on with the 3 of us plus the extended team, and we are going to take all of the information that we've already learned, and we are going to host breakout conversations on those. So you can really we can, you know, engage in conversations. It won't be just on these sessions. There's thousands of research posters. Thousands. So, I mean, you name a topic, whether it's precision medicine, disease-specific, biosimilars. I mean, there are so many things, pain, fatigue, it's all there.
Everything, yeah, it's all there. So exercise, yeah.
Exercise, yes. So we'll invite all of you to vote on those and tell us which ones do you want to talk more about, and then we'll add those to some of the live sessions as well. So if you'd like to join us on this journey over the next couple of months as we really dive into what we're learning at the conferences, you can either go directly to our website while you're there anyway, and it's just aiarthritis.org, and on the front page there's a slider with all of kind of these top projects we're doing, and this one's on it. Click on it, you'll go right to it. Or you can go to bit.ly/AiArthritis EULAR 20. And it's just a sign-up form, again, free, and it'll let us know that you're interested, and we'll be able to send you specific information on how you can get more involved.
And invite you back, yeah.
Yep, and other than that, we will be returning. You will see a new video on YouTube every Thursday until we're done reviewing the session. So a few more weeks, and other than that, we really do hope that you will join us, because we're learning a lot, and you know, only together can we really solve the problems of tomorrow, and that includes all of your voices. So
absolutely.
All right. We will also share the links to registries and everything else that you can get involved with our organization on this feed as well. So thank you all for joining us. Until next week, when we review more, we will see you then. Bye-bye.
Bye, everybody.
Bye.